hypothalamic hamartomas this summer in Calgary, because I'm sure that what you're hearing today is largely inspired by the events that happened in Calgary, where we discussed hypothalamic hamartomas as a lifelong syndrome. My topic today is going to focus specifically on infancy and what happens if seizures and epilepsy are diagnosed early on in the life of a child with a hypothalamic hamartoma. So, as you all know, epilepsy is a lifelong syndrome and it changes its phases over time. And my focus will be on the little ones here and how epilepsy starts in hypothalamic hamartomas. I want to discuss three main questions with you. One of them is, what is usually the earliest seizure type that we see in affected kids? How do we diagnose hypothalamic hamartomas in infancy? And last but not least, does it make a difference for the treatment of hypothalamic hamartomas if they occur that early? I want to start with two patients that I met during my time in Freiburg. They are both very similar. And one of them is a 5-month-old, otherwise healthy boy who started having a typical West syndrome with infantile spasms and hypothalamic that led to the diagnosis of the hypothalamic hamartoma at that age. Retrospectively, when we talked to the parents, he had had gelastic seizures since the first months of life. But as you can imagine, the parents just thought, hey, he's cute, he laughs in sleep, or he's just happy, or why is he silly now? But usually we don't interpret laughing in a baby as a pathological or abnormal behavior. He had a cessation of his spasms under high-dose steroids, but the gelastic seizures remained refractory to all anti-epileptic treatments. And you can see here on the left the hypsarrhythmia, then the hypothalamic hamartoma, and what happened after we treated him with steroids. The second case is a 6-month-old girl with Pallister-Hall's syndrome and a mutation in the GLI3 gene. She also presented to our service with a West syndrome with infantile spasms and hypsarrhythmia, and that led to the diagnosis of a hypothalamic hamartoma and starting the investigations for the specific gene. However, of course, her other abnormalities had been recognized earlier. Retrospectively, she also had gelastic seizures that occurred since the first months of life, but parents again were not aware of those and only recognized them when explicitly asked for them. The cessation of spasms with high-dose steroids was similar to the first case. Again, her gelastic seizures were not easy to treat with medications, and you can see the hypothalamic hamartoma here. So what do these two cases have in common? They have the onset of infantile spasms led to the diagnosis, but both patients actually had seizures prior to this diagnosis. We are also able in both cases to treat the spasms successfully with standard protocols, but the gelastic seizures required a surgical intervention. So out of these two cases, I asked the question, is this something typical for hypothalamic hamartomas, or do we just have two random cases? And there is, of course, not a big literature overview existing. So what I did is I played the count and I counted the different case reports. So there are 6 cases in Freeman et al., 2 cases in Muladi, 7 cases in Kerrigan et al., 1 case in Fox et al., and 3 cases in Caracas et al. Overall, when you look at the big series of hypothalamic hamartomas, 1 to 10% of the cases start or have the first seizures recognized as infantile spasms. So if we look at this overall table now, and that's all the papers you've just seen summarized, and if you do the counting, what happens is that you can see that in 15 out of the 19 patients, the diagnosis was not made with the first occurring seizure type. And the first occurring seizure type in all of the 15 cases were gelastic seizures. 13 out of the 19 had their first diagnosis, had their first seizure not as spasms, but as something else. 9 of them had the infantile spasms with hypsarrhythmia. 10 had infantile spasms without hypsarrhythmia. And interestingly, 11 had a typical onset of infantile spasms plus hypsarrhythmia in the typical age range, so before 12 months of age, so they would have had a typical West syndrome. If we add our own cases, you can see here that, of course, our cases were as well ones where the diagnosis was only made with the infantile spasms, even if the infantile spasms were not the first seizure type. Both of our cases had hypsarrhythmia, and both of them were younger than 12 months at time of diagnosis. So now we've talked a little bit about gelastic seizures and infantile spasms, but of course the question is also, is there other early seizure types which we have to be aware of? There is quite a big case series who looks at Lennox-Gastaut syndrome and hypothalamic hamartomas. This was defined as multiple generalized seizure types, spikes, low waves on the EEG, as well as an associated developmental regression. And you can see that 14% of the patients met these criteria. They had an average seizure onset at 0.9 years. If we look at, again, which these Lennox-Gastaut kids, what was their first seizure type, 86% had gelastic seizures first, 30% had infantile spasms prior to Lennox-Gastaut, so you obviously can directly involve into Lennox-Gastaut syndrome. 82% had myoclonic seizures, 76% atonic and tonic seizures, 21% atypical absences, and 62% generalized tonic-clonic seizures at the time where the paper looked at these individual cases. There are also some rare case descriptions of different seizure types. This is a description where they're talking about something which is called a struggling status. Basically, this is a kid who woke up at night. She would have turned down the corners of her mouth, have inconsistent head turning, sometimes to the left, sometimes to the right, and then she would have something which was very much like a hypermotor frontal seizure, so she would have lip flapping, hand wiggling, pedaling. The authors describe this as being very behavioral on the EEG, so if they wouldn't have on the video, so if they wouldn't have a clinical EEG correlate, they wouldn't have been sure that it's actually ictal. But she had up to 150 of these short seizures in 48 hours, and she didn't have other seizure types at that time. Another paper looks at what they call trance-like state. These were very long episodes of unresponsiveness that lasted between 2 and 12 hours, starting at day 4 of life. The kid was unresponsive to painful stimuli or social interaction, had no eye contact, and often these episodes were initiated by a shrill cry. If you look at the timeline, and this is again up here, all the different age times and age variations when she was looked at, you can see again that this is at her time of diagnosis, and I can tell you that it was not her seizures, but her precocious puberty which led to the diagnosis. But you can see here that he had this trance-like states first, and then later on started gelastic seizures which aggravated over time. She had a first normal routine EEG, which was why these trance-like episodes were first thought to be non-epileptic, but then later on had a longer EEG, which clearly showed an EEG correlate during this episode. And as I already said, it was her puberty, not her seizures, which actually led to the early diagnosis. So we've talked about early seizure types, some more common, some less common. And next I want to move on and talk to you what is important for making a diagnosis of hypothalamic hamartomas in infancy. And I think what you have seen already, that in the of all the presented infantile spasm cases, of course, many had no prior EEGs because they were only diagnosed at the time of West syndrome. But actually 8 had a prior EEG, and out of these 8 EEGs, 5 had a completely normal routine EEG. And I think that's important to acknowledge, because if you think about a baby doing weird laughs, and as a result, you're thinking about hypothalamic hamartomas and ordering an EEG, and then the EEG comes back normal, you might have had the right idea, but rule out the hypothalamic hamartomas on the basis of the EEG, which then might lead you down a wrong path. I also looked at our Freiburg data for the kids who were diagnosed in the first year of life, and these were 8 kids. Out of these 8 kids, 3 had a first normal EEG, so this is not an uncommon pattern. So there's 2 problems here. First of all, gelastic seizures often don't trigger an EEG because they're not considered abnormal, but then if they are considered abnormal and the EEG results to be normal, people are not aware that they might need an MRI to get a better diagnosis. And then those kids who often get a very early diagnosis, this is because of severe behavioral challenges, because of infantile spasms, or because of endocrine symptoms, rather than the first seizure type. I want to make you aware of another challenge which we often face, and I think that is that we underestimate the burden of disease in hypothalamic hamartomas. And this is from a group of kids who had all early onset and then early long-term monitoring in our unit. And they were coming for pre-surgical investigation. So this was not a sleep study. But what you can see is that they have a significant burden of small seizures during sleep, between 1 every 2 hours to 6 every hour. Plus, they have a lot of additional arousals every hour, and they stay awake quite a long time after these arousals. So we are actually talking about a severely interrupted sleep in these kids. Again, the problem is that the parents don't come to you and they say, my kid is a really bad sleeper, because in this age group, we think it's normal that kids don't sleep. And then there's bad sleepers and there's good sleepers. But these kids have such a substantial burden on interruption of their sleep that it's hard to imagine that this is not relevant for their cognitive development or their day-to-day function. So we have to be aware of this, that if a parent tells you, I think the kid has 1 or 2 seizures every night, it might very well be 10 and we are just not aware of it. So be aware of nighttime events and be aware that, again, they often don't trigger long-term monitoring. Last but not least, I want to ask the question, is there a difference in treatment for HH in infancy? And not all of the cases in the literature, we are back to my counting, have data on that. But in total, we have data of 13 patients. And as I've told you already, many of the infantile spasms can be treated with standard infantile spasm protocols. And you can see here 61% actually have a complete response of their infantile spasms. 3% have non-resolved spasms. That's actually higher than most of the structural West syndromes that we are aware of. So there seems to be quite a good response. However, all of these kids remain to have gelastic seizures afterwards, and these gelastic and other seizures need to be treated with surgery. In this case count, there were kids treated for surgery because of remaining seizures, and also these 3 kids who had non-resolved infantile spasms were surgically treated. Overall, post-surgical seizure freedom was 7 out of the 13. And what you can see here again is our 2 cases. So they also resolved after infantile spasms. They also had remaining other seizures. They also underwent surgery, and one of them actually became seizure-free. I think a very important question is, when do we treat? And there's actually quite good literature on hypothalamic hamartomas for them. One of them is actually from the Lennox-Gastaut paper. They could clearly show they had a range from 1 to 16 years of seizure onset to surgery. And there was a clear negative correlation between the time of surgery or the time to surgery, so the longer it took to get to surgery, and the seizure outcome. And you can see here that the seizure outcome with seizure-free 24% and 90% reduction 42% is actually quite good in these severely affected individuals. But as I said, the longer we wait, the less likely it is that it is good. And there's this famous paper from the group in France who actually looked at this in detail. They had 3 subgroups: the ones who had seizures for less than 10 years, more than 10 years, and more than 20 years. And you can see clearly the blue are the seizure-free patients, and their proportion significantly shrinks with duration of epilepsy. I think most people working in hypothalamic hamartomas have this idea that you have a core which starts the seizures, and then a more and more evolving network which includes the cortex, and which makes it really hard to stop seizures if the epilepsy has been really established. So if we talk about the lifespan and we look at the little babies, we have learned now that most of them start with scholastic seizures. Some of them start with infantile spasms. Some of them progress to LGS and afterwards have multifocal seizures. We don't know whether there is a point of no return and what is the sweet spot for the infant intervention, but we have evidence that longer wait is not beneficial for our patients. So to summarize what I've been saying today is the earliest seizure type is often scholastic seizures, and they are often not recognized, and they can co-occur with infantile spasms. There is challenges to diagnosing HH in infancy because of the normal EEG, the subtle symptoms of the seizures, and the overlap of the seizure symptoms with normal baby behavior. And last but not least, when we treat HH in infancy, infantile spasms are often treatable with standard protocols. Scholastic seizures remain unchanged with anti-seizure medications, and early surgery might reduce the risk of a surgical failure, so you should definitely consider it. I also want to make a point that I've been talking about seizures today, but we know that treatment in HH is not only seizure freedom. So we also have to look at comorbidity, and we currently have no evidence on which treatments we should do when to reduce comorbidity and its long-term challenges. With this, I would like to thank the organizers for inviting me. I'd like to thank you for your attention. I'm going to be open for questions. And of course, I would like to leave you with this wonderful pictures from the International Symposium in Calgary, which was real fun, and we learned a lot during this time.